I'm going to be discussing the future of AR-directed therapy. Here's my conflict of interest statement. Learning objectives for today. First, we're going to be reviewing the novel approaches to target the androgen receptor. Then we'll discuss novel approaches to target androgen precursors. And we'll finish up by reconsidering de-escalation. So AR pathway inhibition remains the backbone of treatment for metastatic hormone-sensitive prostate cancer. We start with GnRH analogs that target testicular production of testosterone and knock out about 95% of testosterone production for a male. Over the last decade, we've discovered that if you further intensify hormone therapy by either adding a CYP17A1 inhibitor to target adrenal androgen precursor biosynthesis, or just block the androgen receptor itself with competitive androgen receptor antagonist, we can improve overall survival. Yet, despite this approach, many patients with metastatic CRPC have tumors that remain addicted to AR after progression on an AR pathway inhibitor. There are multiple different mechanisms that the tumor can take to do this. The figure on the left is showing many of these. Tumors can have amplification of the androgen receptor. You can have mutations within the androgen receptor's ligand binding domain so that the tumor can use non-testosterone ligands to activate itself, or even have splice variants so they don't need a ligand at all for activation. You can have other pathways that independently activate AR, or just activation of the genes downstream of AR through mechanisms such as the glucocorticoid receptor. About 5 to 10 years ago, some really nice preclinical work identified that you can also have epigenetic activation of an enhancer upstream of AR to again result in increased AR signaling. And this was all put together very nicely in a translational study from the Fang lab that was just put out this year that showed that after progression on an AR pathway inhibitor, you get an increase in your copy number of AR, as well as an increase in your copy number of the AR enhancer. So we put together this figure to show the novel approaches to target AR signaling after AR pathway inhibition that I'm going to be discussing today. So there's opevesostat, although I'm sure I'm mispronouncing that one, but that's a CYP11A1 inhibitor to target adrenal androgen biosynthesis. We have PROTAC degraders that are targeting, or protein degraders that are targeting the androgen receptor. And then finally, we're going to be discussing RIPTAC therapies that try to target the androgen receptor and then a downstream gene. So diving into AR protein degraders, also called PROTAC degraders. So what is a PROTAC? So a PROTAC has 3 components to it. There's a ligand for a protein of interest. In our case, that's going to be AR. There's a linker, and then there's a ligand for an E3 ligase. And so what this does conceptually is that it goes and you bind the protein of interest, AR, and then it recruits the E3 ligase, and it forms a stable ternary complex. And just by forming that complex, the proximity results in ubiquitination of the protein of interest by the E3 ligase and targets it for proteasomal degradation, and you actually just get total destruction of the protein. And these protein degraders have totally different PK and PD. There's new terms that are being used for these because one molecule can continue to degrade more and more AR. And you can even see kind of AR expression go down to almost none when some of these compounds are used. AR was the first protein of interest that was targeted, and there are 3 molecules that have been developed as protein degraders for AR. The first 2 are coming out of a company spun out of Yale. There's ARV-110, also called bavdegalutamide. That's not currently being developed further. The next generation from that company was AR-766. That drug was recently licensed to Novartis, and development is unclear at this point. And then the one we're going to be discussing in more detail is this BMS ligand-directed degrader, 986365. So with 986365, the BMS compound, again, target site is the AR ligand binding domain, and the E3 ligase that it's recruiting, there are hundreds of E3 ligases, but the one it's recruiting is CBRM. And this compound is a little bit unique. They're trying to get away from the PROTAC degrader terminology. They're calling it a ligand-directed degrader, and then it still has activity as an AR antagonist, similar to what we see with APA, DARA, ENZA. And this has been studied in a phase 1 trial that was just published at the end of 2024, early 2025. And you can see the adverse events reported here. Overall, it was pretty tolerable. We had this open at our institution. But most notable is you do have a high incidence of new cardiac toxicities. So prolonged QTC in about 50% of patients, bradycardia in about a third of patients. And some of these did result in hospitalization, grade 3 AEs for some of those cardiac events. Now, from an efficacy perspective, Tanya alluded to this. Most because of the Arnavus compounds, a lot of the focus initially has been on the ligand-binding domain mutated patients. And you can see in this waterfall plot, yes, there is definitely activity in ligand-binding domain mutated patients. But you can also see to the left of that there's quite a bit of activity in ligand-binding domain wild-type patients. And conceptually, that makes sense, right? Ligand-binding domain mutations is just telling us that tumor remains addicted to AR. And I just showed you how there's a bunch of other mechanisms how these tumors can remain addicted to AR despite not having ligand-binding domain mutations. And then kind of important for further development, if patients had not received any prior chemotherapy, they had significantly longer time to disease progression at 16 months versus patients who did receive prior chemotherapy at 5 months. There is a phase 3 trial called the RECHARGE trial that is activating late spring, early summer this year, and is going to be active internationally and across the US. Okay, moving on to RIPTAC therapy. So this one's the newest of all of them. So what is AR RIPTAC therapy? So this was created by the Craig Crews lab. So this is a medicinal chemistry lab from Yale. They initially developed PROTAC degraders, and now they've spun off a new company developing these RIPTAC therapies. And again, the protein of interest they're first focusing on is AR. RIPTAC stands for Regulated Induced Proximity Targeting Chimera. And what these molecules are doing is they have, a ligand for a target protein, in our case, AR. Then they're linked to a ligand for an essential protein. So this is different. In the abstract, this is all that's been presented so far is this abstract. In the abstract, they do not tell us what the essential protein is, but conceptually, what you're trying to do is basically form a stable complex, and then you're actually using AR as a way to identify the prostate cancer cell, but you're not actually targeting downstream signaling of AR. You are it's abrogating the downstream signaling of the protein essential for cell life for prostate cancer. And it'll be interesting to see the different essential proteins they target. There is preclinical data out for HLD-0915, which is the RIPTAC therapy. This first figure is showing that you need AR expressed to have cell death. Second group of figures is an experiment where they have the RIPTAC therapy that has both domains, and then they created a second compound that does not bind to the essential protein. And what you can see is you need to bind to the essential protein to form the stable complex and ultimately result in cell death. So just proving mechanism right here. And they have an in vivo model with a very AR-resistant tumor with AR amplifications, ARV7 splice variant, and you can see that this was resistant to enzalutamide, resistant to a vehicle, but responded to the higher doses of the RIPTAC therapy. And this is coming soon, again, probably later this spring or early summer in a phase 1 clinical trial. All right, so then shifting to targeting adrenal androgen biosynthesis and precursors. Abiraterone acetate inhibits CYP17A1. You can see the whole steroid biosynthesis pathway from medical school days. And abiraterone improves survival across advanced prostate cancer. And due to the success of that approach, we have this compound called opevesostat that inhibits the first step of steroid biosynthesis, converting cholesterol to pregnenolone. And so opevesostat has been studied in a phase 1/phase 2 study. In that study, it was given with both dexamethasone as well as fludrocortisone because we are inhibiting steroid biosynthesis right at the top and knocking out probably everything thereafter. Adrenal insufficiency was pretty common, about a third of the patients in total across this study. And then what you're seeing on the waterfall plots showing PSA response on the right, the top is the phase 1 study. In that study, they allowed patients with any AR mutation mutation status. And what you can see is all the little red asterisks over to the right with all the declines are all the patients who had AR mutations. And you can see there's quite a bit of difference in response there. That resulted in phase 2, they mandated that patients have an AR mutation in order to enroll, and in that group, the PSA 50 response rate was about 50%. And so this, the molecule has been acquired by Merck, and there are already 2 phase 3 clinical trials going on across the world. Omaha 1, that's looking at, I'm gonna mess this up, I think it's metastatic CRPC, post-AR pathway inhibitor, and post-taxane, I might be wrong there. And then Omaha 2A, that's just moving it earlier, it's just post-AR pathway inhibitor. These are really big studies. They're like 1,200 to 1,500 patient studies, so it'll be interesting to see what we find here. And then, AR pathway inhibitor monotherapy and intermittent ADT were explored heavily in the 2000s into 2010s, and then kind of went quiet as we shifted our focus to, as Jason alluded to, upfront intensification with both ADT plus AR pathway inhibitors plus docetaxel plus or minus radiation. I think that as there's a bit of a yo-yo happening, that as we're further intensifying a bunch of patients, there is renewed interest from both patients as well as providers in de-intensification, now for select men instead of kind of all comers as we did back in the 2000s, early 2010s. And the studies that are looking at this so far have used PSA to guide who are the men that we're going to de-intensify in. There's 2 main studies that are actively enrolling patients. The first is an industry-sponsored study from Johnson & Johnson called the LIBERTAS study. In this one, everyone gets ADT and apalutamide up front at 6 months. If you're one of those patients who has a really nice response and your PSA becomes undetectable or less than 0.2, then you enter that top group and you get randomized to either continue like we usually would or intermittent ADT while doing continuous apalutamide there, so letting your T levels come back and maybe even getting a bit of a surge of T from still blocking the AR pathway inhibitor. And so we'll see what that study shows. It's a relatively small study. It's about 300 patients. And then there's an even smaller study, 75 patients, that's coming out of the Alliance Cooperative Group. And in this study, it's a similar question, but kind of further time point. So patients who have a PSA that's undetectable a year and a half to 2 years after being on ADT and an AR pathway inhibitor, they stop it. And then the primary endpoint here is a really good one. I think it's treatment-free with normal testosterone levels at a year and a half after stopping. So this will give us some really important initial data that can then guide subsequent phase 3 studies. So in conclusion, metastatic CRPC often remains addicted to androgen receptor signaling after progression on AR pathway inhibitors. There are 3 new drug classes that are targeting AR in men with metastatic CRPC under investigation: AR protein degraders or PROTAC degraders, AR RIPTAC therapy, and then CYP11A1 inhibition for adrenal androgen biosynthesis. And then finally, there remains patient-driven interest in de-intensification of hormone therapy, and current trials are using PSA kinetics to drive de-intensification. Thank you, guys.